Hello and welcome back to the Deep Dive. Today, we are shifting gears. We are moving away from general curiosity and stepping right into the high-pressure, high-stakes environment of the medical examination hall.
That's right.
Specifically, we are simulating a hardcore prep session for a Gujarat University MD anesthesiology student.
Right, and if you are listening to this, you likely have the distinct pleasure or terror of facing a thoracic anesthesia case in your practicals or staring down a 20-mark long theory question on this exact topic.
Exactly.
So for the next hour, I'm going to adopt the persona of your senior faculty member, maybe even that slightly intimidating external examiner sitting across the table, peering over their glasses, waiting for you to slip up.
And I'll be the learner, the resident who has, frantically read Miller, Morgan, and Mikhail and Yao and Artuzio the night before, but needs to synthesize all that dense text into a coherent, passing answer.
It's a lot to bring together under pressure.
It really is. Our mission today is crystal clear. We are cracking the code on one-lung ventilation, or OLV. We are going to cover the indications, the incredibly complex physiology, the hardware, and of course the management of that dreaded intraoperative hypoxia.
It is the absolute bread and butter of thoracic anesthesia. I mean, if you cannot manage OLV, you simply cannot call yourself a thoracic anesthetist.
It's that fundamental.
It is. And from an exam perspective, this topic is a goldmine for examiners. It tests your physiology, your pharmacology, your physics, and your crisis management all at once. So let's get serious.
Let's do it. Let's jump right into Part A, introduction and exam framing. If I'm sitting in the exam hall and I get a question on OLV, or the examiner asks me to define it, how do I set the scene? I need a definition that, screams competence.
You need to be crisp and academic. Do not just say breathing with one lung. That's too simplistic.
Right.
One lung ventilation is defined as the mechanical separation of the two lungs to allow ventilation of one lung while the other is allowed to collapse.
Separation and isolation, those are the key words.
Yeah. Those are the key words. It shows you understand the core principle. You're not just turning one lung off, you're creating a physical barrier between the two.
And strictly speaking, why do we do it? I mean, biologically, we're designed to use both lungs. Collapsing one seems completely counterintuitive.
It is, and that's the central challenge. But it's the defining skill of our subspecialty because it achieves two absolutely critical things. First, it provides a still surgical field, the so-called quiet lung.
Right. The surgeon needs to see what they're doing.
They do. Modern thoracic surgery, especially video-assisted techniques, VATS, is impossible if the lung is inflating and deflating in the surgeon's face. They're working with long instruments through tiny ports. They need a motionless target.
And the second reason?
The second, and arguably more critical reason for patient safety, is it protects the healthy lung from contamination.
Contamination, like from blood or pus.
Exactly. We'll get into the specific indications, but imagine one lung is full of infectious material or is bleeding massively. Without isolation, that material would immediately spill into the healthy, dependent lung, and you'd have an absolute catastrophe on your hands.
But physiologically, this is a disaster, isn't it? I remember reading in Miller's Anesthesia that thoracic anesthesia is often described as a physiological trespass.
That is the perfect phrase to use in an introduction, physiological trespass. It shows the examiner you appreciate the gravity of what you're doing.
So what does that mean exactly?
Think about it. We are deliberately creating a massive right-to-left intrapulmonary shunt. We are collapsing a lung, so ventilation, the V in VQ, becomes zero.
But blood flow continues.
But perfusion, the Q, continues to that lung. So we are actively taking venous blood, running it through a lung that has no oxygen, and then mixing that unoxygenated blood right back into the arterial circulation.
It's a controlled physiological crisis.
Controlled crisis is a great way to put it. Our entire job during OLV is to manage that crisis and keep the patient safe despite the trespass we've committed.
I like that framing. Before we get into the weeds of how we survive that crisis, let's look at the exam patterns. Looking at the DNB questions and some Gujarat University past papers, how does this topic usually appear?
You need to be ready for three distinct formats. First, the long question. This is your 10 or 20 marker. Discuss indications, physiology, and management of hypoxia during OLV. That requires a structured, logical essay.
So a full-on brain dump, but organized.
Organized is the key. You need headings, subheadings. You can't just ramble. Second, you'll see it as short notes.
Okay, like 5 markers.
Exactly. You'll see hypoxic pulmonary vasoconstriction or double lumen tubes or physiology of the lateral decubitus position as standalone 5-mark questions. They're testing specific pockets of your knowledge.
And the viva, that's where the nerves really kick in.
In the Viva, they will physically hand you a double lumen tube and say, identify this. Tell me about it. Or they'll give you a scenario.
The dreaded scenario.
The classic one. You are doing a lobectomy, the patient is on one lung ventilation, and the saturation drops to 85%. What do you do?
And you need a stepwise answer.
You need an algorithm, a calm, logical, stepwise answer. If you stumble on the management of hypoxia, you fail the station, period. Safety is paramount.
Okay, that definitely sets the stakes. Let's move to Part B, indications. This seems like it could be a rote memory section, but I know examiners are picky about the order and classification. How do we present this to impress them?
Presentation is everything.
Yeah.
Do not just vomit a list of surgeries onto the page. You must classify them logically.
Yeah.
The standard Text Morgan, Yao, Miller, they all classify indications into absolute and relative.
Absolute and relative, and the order matters.
The order matters tremendously. If you list a lobectomy, which is a relative indication, before you list a massive lung abscess, which is absolute, you show the examiner you don't understand clinical priority. You put the life-saving indications first.
Okay, so let's start with the absolute indications. These are the must-knows, the non-negotiables.
The first category of absolute indications is isolation for contamination control. The goal here is to prevent spillage from a diseased lung to a healthy lung.
So protecting the good lung.
Protecting the good lung at all costs. Think about infection. Imagine a patient with a massive lung abscess or severe bronchiectasis. We're talking about a lung cavity filled with liters of pus.
Right.
If that pus spills into the healthy lung when you turn the patient lateral, you've essentially caused bilateral pneumonia. You've destroyed the patient's only means of oxygenation. It's catastrophic.
And hemorrhage fits in here too, I assume.
Yes. Massive hemoptysis. If a patient is bleeding heavily from a tumor or a vessel in one lung, you must isolate that side. You have to stop the healthy lung from literally drowning in blood.
Okay, so infection and hemorrhage, that's category 1 for absolute indications.
Yeah.
What's the second absolute category?
The second is called differential lung ventilation. This is a bit more of a physiological concept. It's for situations where the two lungs have such different mechanical properties that they simply cannot be ventilated together effectively via a single tube.
The classic example being the bronchopleural fistula.
Exactly. A bronchopleural fistula, or BPF, let's walk through that. A fistula is an abnormal connection between the bronchus and the pleural space.
So air is leaking out.
Air is leaking out. If you try to ventilate that patient with a standard tube, all the positive pressure you apply follows the path of least resistance. It goes straight out the fistula and into the chest drain. The lung doesn't inflate. The air just bypasses it entirely.
And the patient becomes hypoxic and hypercarbic.
Very quickly. So to ventilate that patient at all, you must isolate the good lung and ventilate it alone while the fistula side is left open.
I also have giant unilateral bulla on my list here under differential ventilation.
Correct. A bulla is a large, thin-walled air sac. If you apply positive pressure ventilation to a patient with a giant bulla without isolation, one of two bad things can happen. The bulla can expand and rupture, causing a tension pneumothorax,
Which is an emergency.
a life-threatening emergency, or the bulla can act like a compliance sink. It's so floppy that it steals all the tidal volume from the healthy parts of the lung, leading to poor gas exchange. So isolation is absolute.
And there's one more rare one that always seems to pop up in exams. Unilateral bronchopulmonary lavage.
Yes, specifically for a condition called pulmonary alveolar proteinosis. It's a rare disease where the alveoli fill up with a thick, proteinaceous, milky fluid.
Right, and the treatment is basically to wash it out.
Literally, the treatment is to wash the lung out with liters and liters of warmed saline. Obviously, you cannot drown one lung with saline while the other is trying to breathe unless they are perfectly, absolutely isolated from each other.
So to summarize for an exam answer, absolute indications are 1, protection from contamination like infection or hemorrhage, and 2, situations requiring differential ventilation like a BPF or a giant bulla.
Perfect.
Now let's talk about relative indications. In the real world, this is actually 95% of what we do, isn't it?
It is. This category is broadly termed surgical exposure. We collapse the lung to make the surgeon's life easier, the surgery faster, and often safer.
How do we break this down?
We can subdivide this into high priority and lower priority, though the lines are blurring. High priority would include major procedures like a thoracic aortic aneurysm repair, a pneumonectomy removal of the entire lung, or an upper lobectomy.
Why is an upper lobectomy considered high priority compared to, say, a middle or lower lobectomy?
It's purely about anatomical access. The upper lobes are harder for the surgeon to get to and manipulate, but let's be honest, in the modern era of minimally invasive surgery, this distinction is becoming a bit academic.
You mean because of VTS?
Exactly. If you are doing video-assisted thoracoscopic surgery VATs where the surgeon is working through tiny keyhole ports with a camera, OLV is effectively mandatory. They cannot see a thing if the lung is inflating and deflating. So for any VATS procedure, you can consider it a very strong relative, almost absolute indication.
So for the exam, I should list isolation for protection first as the absolute indications, then list surgical exposure as the relative category, but be sure to mention that in modern practice, especially with VATS, it's essentially required.
Exactly. That nuance shows you understand both the textbook theory and the reality of the modern operating theater. It's a high-scoring approach.
All right, let's dive into Part C, Physiology. This is what you call exam gold. If I can explain this clearly, I passed the physiology station. We talked about the shunt earlier. Let's really unpack the ventilation perfusion, or VQ, changes.
Okay, let's visualize the switch. The patient is anesthetized in the lateral position, and you're ventilating both lungs. VQ is mismatched, as we'll discuss, but it's relatively stable. Then you tell your assistant to clamp the lumen to the non-dependent lung, let's say the left lung is up, and you clamp its tube.
So ventilation to that lung instantly stops. V equals 0.
Instantly. V is 0. But the heart doesn't know you've done this. It keeps pumping blood. The right ventricle keeps sending unoxygenated blood to the pulmonary artery, which splits and sends blood to both the right and the left lung.
So perfusion Q continues to that collapsed left lung.
It continues. And so that blood goes through the capillaries of the collapsed lung, picks up 0 oxygen, and then returns via the pulmonary veins to the left atrium. That is the definition of a right-to-left shunt.
Now let's look at the math, because the textbooks like Yao and Artuzio love the math. What kind of numbers are we talking about here?
In a normal, healthy person, the physiologic shunt, the small amount of blood that bypasses the lungs, is less than 5%. It's negligible.
Okay.
When you start OLV, assuming the patient is on their side, roughly 40 to 50% of the cardiac output is still directed to that non-dependent lung, at least initially.
So theoretically, if I just clamp the tube without any compensatory mechanisms, I should have a 40 to 50% shunt.
Theoretically, yes. And a 50% shunt is incompatible with life. Your PO2 would plummet instantly. You would be profoundly cyanotic within minutes. But that's not what happens.
Why not?
Because the body has a powerful intrinsic defense mechanism. And in reality, the shunt usually settles around 20 to 30%. Still significant, but manageable.
And that defense mechanism is hypoxic pulmonary vasoconstriction. This brings us to point 4. I see this asked as a short note all the time. Write short notes on HPV. How do I structure that answer to get full marks?
Okay, for a short note on HPV, you need 4 parts: definition, mechanism, role in OLV, and factors that inhibit it.
Let's start with the definition.
Start with a precise definition. HPV is a protective, local physiologic reflex where pulmonary arterioles constrict in response to low alveolar oxygen tension.
The emphasis is on alveolar oxygen.
Crucial distinction. It is not the oxygen in the blood, the PO2, that triggers it primarily. It's the lack of oxygen in the air sac, the PaO2 itself. The lung senses hypoxia locally and reacts locally.
Okay, that's the definition. Now the mechanism. The examiner wants to know the cellular level stuff. How does the lung know to constrict?
It's incredibly complex and not fully understood, but here are the key words for your answer paper. It involves an oxygen sensor in the smooth muscle cells of the pulmonary arteries. Under hypoxic conditions, this sensor leads to an inhibition of voltage-gated potassium channels.
Okay, stick with me. Potassium channels are inhibited. What happens next?
Normally, potassium leaks out of the cell, keeping the inside of the cell negatively charged. When you inhibit these channels, potassium is trapped inside the cell. Positive charges build up. This causes the cell membrane to depolarize.
And that depolarization is the trigger.
That's the trigger. That change in voltage opens up L-type voltage-gated calcium channels. Calcium then floods into the cell from the outside.
And calcium causes contraction in smooth muscle.
Calcium binds to chymodulin, which activates myosin light chain kinase, the actin-myosin filament slide, and boom, vasoconstriction.
Is there any other pathway involved? I seem to remember something about nitric oxide.
Yes, that's another important piece of the puzzle. Normally, healthy, oxygenated lung tissue constantly produces vasodilators like nitric oxide or NO and prostacyclin. They keep the vessels relaxed.
So when the alveolus becomes hypoxic.
Nanosynthesis drops, so you're getting a double whammy. You have an active vasoconstriction process happening due to the calcium influx, and at the same time, you're losing the background vasodilation. The balance tips heavily toward constriction.
So the vessel effectively strangles the blood flow to the useless, collapsed lung.
Exactly. It's an elegant autoregulation system. It diverts blood away from the hypoxic lung towards the ventilated oxygen-rich lung. This is what reduces the shunt fraction by about 50%. So instead of that catastrophic 50% shunt, you get a more manageable 20 to 25% shunt.
Is this response instant? Does it happen the second I clamp the tube?
That's a great question, and it's a detail that will get you extra marks. It's biphasic.
Biphasic.
Yes. Phase 1 is rapid. It starts within seconds of the onset of hypoxia and reaches about half its maximal effect at around 20 to 30 minutes. But then there's a bit of a lull.
In phase 2.
Phase 2 is a slower, more sustained response that kicks in after about 40 minutes and continues to increase for up to 2 hours.
Which implies that the most dangerous time for hypoxia might actually be in that first 20 to 30 minutes right at the start before that phase 2 reinforcement really kicks in.
100%. That first half hour of one lung ventilation is when you are most physiologically vulnerable and need to be most vigilant.
Now here is the classic Viva trap, the examiner asks. What factors inhibit HPV? Basically, what can we as anesthetists do to accidentally kill this life-saving reflex and cause hypoxia?
This is a huge topic. If you inhibit HPV, you increase the shunt and the patient's saturation will fall. You need to know this list cold.
What's at the top of the list?
The biggest culprit is our own drugs. Volatile anesthetics. Halothane, isoflurane, sevoflurane, dysflurane, they are all direct vasodilators, and they inhibit HPV in a dose-dependent manner.
So the more gas I give, the worse the inhibition.
Precisely. The general rule of thumb, the one to quote in the exam, is keep the volatile concentration below 1 ms. At concentrations greater than 1 ms, they significantly blunt the HPV response.
So if I'm struggling with oxygenation during OLV, turning up the sevoflurane is the absolute wrong move.
The worst thing you can do. It might deepen the anesthesia and stop the patient from moving, but it will worsen the shunt and make the hypoxia more profound. This is a major reason why TIVA, or total intravenous anesthesia, with propofol is so popular for thoracic cases. Propofol does not inhibit HPV.
What about other drugs?
Any direct vasodilator. Think about drugs we might use for blood pressure control. Nitroglycerin, sodium nitroprusside, hydralazine. They'll dilate everything, including the vessels in the collapsed lung, which overrides HPV. Beta agonists like salbutamol can also inhibit it.
What about physiological factors, things not related to drugs?
Alkalosis is a big one, both respiratory and metabolic. Hypocapnia, a low CO2 from overventilating the patient, causes pulmonary vasodilation and blunts HPV. So if you're hyperventilating the patient, thinking you're helping by blowing off CF2, you might actually be worsening their oxygenation.
That's a key clinical point.
It is. Also, extreme changes in volume status. Hypervolemia can mechanically force vessels open. Hypothermia inhibits the response. And finally, infection. A septic or infected lung often doesn't vasoconstrict well because of all the inflammatory mediators, which are potent vasodilators.
Okay, let's move to point 5, the effective anesthesia and positioning. We almost always do these cases in the lateral decubitus position. The patient is lying on their side. How does that by itself mess with VQ matching?
This is a fantastic Viva question. You have to explain it as a tale of two states, the awake patient versus the anesthetized and paralyzed patient.
Let's start with the awake patient lying on their side. What's happening?
In the awake patient, gravity pulls blood down. So the dependent lung, the bottom lung, gets more blood flow, more perfusion.
Okay, perfusion goes down. What about ventilation?
You'd think ventilation might go to the top lung because it's less squashed, but the opposite is true. In the awake, spontaneously breathing patient, the dependent part of the diaphragm is pushed up into the chest by the abdominal contents. It's more curved.
And a more curved muscle is a stronger muscle.
By the law of Laplace, being more curved gives it a mechanical advantage on contraction. It acts like a stronger piston. So in the awake patient, the bottom lung gets more blood and more ventilation. V and Q are pretty well matched.
So awake lateral is actually quite efficient. Now,
Yeah.
what happens when we induce anesthesia and paralysis?
Everything falls apart. First, you paralyze the diaphragm. It turns from an active piston into a floppy passive sheet. Now, the weight of the abdominal contents, the liver on the right, the stomach and spleen on the left, pushes up and crushes the dependent lung. It loses compliance.
So ventilation shifts.
Yes. Air is lazy. It follows the path of least resistance. So with positive pressure ventilation, the air preferentially goes to the non-dependent or upper lung, which is less compressed and more compliant.
But gravity hasn't changed. Blood still goes down.
Exactly. Gravity still pulls blood to the dependent or bottom lung. So now you have a massive VQ mismatch. The blood is going down, but the air is going up.
Blood goes down, air goes up.
It's the worst case scenario for gas exchange. We call this the 40-60 rule as a rough guide. In the lateral position under anesthesia, about 60% of blood flow goes to the dependent lung, and 40% goes to the non-dependent lung. But most of your ventilation is going to that non-dependent lung with less blood flow. This is why the dependent lung is so prone to atelectasis even before you start OLV.
That physiology really sets the stage for the challenge. Now let's talk about the tools we use to manage this. Part D, techniques and devices for OLV. Point 6, lung isolation techniques.
You have 3 main weapons in your arsenal. Number 1, and the most common, is the double lumen endotracheal tube, or DLT. That's the gold standard.
What are the other options?
Number 2 is the bronchial blocker. And number 3, which is usually reserved for emergencies or very small pediatric patients, is endobronchial intubation with a standard single lumen tube. Basically just intentionally main stemming a regular tube.
Let's focus on the exam favorite. Point 7, the double lumen tube. Describe it for the listener who can't see one right now.
A DLT is essentially 2 tubes of different lengths bonded together side by side. They're usually D-shaped in cross-section to save space. One tube is shorter and ends in the trachea. That's the tracheal lumen. The other tube is longer and is designed to extend into a main stem bronchus. That's the bronchial lumen.
And they have 2 cuffs.
It has 2 cuffs and 2 pilot balloons. There's a large tracheal cuff, usually white, which is a high-volume, low-pressure cuff, just like a standard ETT. It sits in the trachea and seals the entire airway.
And the second cuff?
The second cuff is the bronchial cuff, which is usually blue. It's smaller and sits inside the bronchus to seal just that one lung. Traditionally, these were low-volume, high-pressure cuffs, which carried a risk of ischemic damage, but modern ones are much better.
Okay, the eternal question. Left versus right DLT. The patient is having a right-sided thoracotomy. Which tube do I choose?
This is a classic trick question. In 90 to 95% of all cases, the answer is you choose a left DLT.
Even if you are operating on the right lung?
Even if you are operating on the right lung, you place a tube in the left main stem bronchus and ventilate the left lung while the right lung, the surgical lung, collapses.
Why? Why not match the tube to the bronchus on the non-operative side? It seems more logical.
It's all about the anatomy and the margin of safety. The left main bronchus in an adult is relatively long, about 5 centimeters before the first branch, the left upper lobe, takes off. It's like a long, safe landing strip. It's easy to park a tube there without blocking anything.
And the right side is different.
Dramatically different. The right main bronchus is extremely short, sometimes only 1.5 to 2 centimeters before the right upper lobe bronchus originates. It comes off at a very sharp angle.
So if I try to place a right DLT, I risk blocking the right upper lobe.
Almost guaranteed. If the tube is just a little too deep, the bronchial cuff will cover the RUL orifice and you'll collapse the entire right lung when you only meant to ventilate it. If it's too shallow, the cuff will herniate back into the trachea and you won't get good isolation.
I've seen right DLTs have a special slot in the cuff.
They do. To solve this problem, right DLTs have a special ventilated slot, like a Murphy's eye, on the side of the bronchial cuff that you must align perfectly with the RUL orifice using a bronchoscope. It is technically very difficult, and the tube can easily get dislodged. It's a last resort.
So when do we use a right DLT? What are the specific indications?
Only when you absolutely cannot use the left bronchus. For example, if there's a large tumor inside the left main bronchus that you can't get past, or if there's been a trauma, a left-sided bronchial rupture, or sometimes a descending thoracic aortic aneurysm can compress the left bronchus so much you simply can't pass a tube, only then do you reach for the right-sided tube.
Got it. Now, point 8, bronchial blockers. These seem to be gaining popularity. When should I be thinking about using a blocker instead of DLT?
The number one reason to think blocker is difficult airway.
Why is that?
DLTs are bulky, they're stiff, they're large, and they have an aggressive curve. If you have a patient with a known difficult airway, a Malampati 4, limited mouth opening, poor neck extension, you do not want to be wrestling with a DLT. The risk of trauma or a failed intubation is too high.
So what's the strategy?
The strategy is you secure the airway first with a normal, familiar single lumen tube, maybe over a fiber optic scope, confirm you're in. And then, once the airway is safe, you pass the bronchial blocker through the single lumen tube and guide it into position.
Or if the patient already has a tracheostomy.
A perfect indication. You can't easily put a long, curved DLT through a short, straight tracheostomy stoma. A blocker passed through a single lumen tract tube works great. Another key indication is if you anticipate the patient will need post-operative ventilation.
Right, because you can't leave a DLT in for long.
You can't. It's uncomfortable and traumatic. So if you use a DLT, you have to exchange it for a single lumen tube at the end of the case, which is a high-risk procedure in a post-thoracotomy patient. With a blocker, you just deflate the balloon and pull the blocker out, leaving the standard ETT in place.
What are the downsides then? Why don't we just use blockers for everyone?
The two main problems are slow lung deflation and easy dislodgement. A DLT has a huge lumen to let air out and for suctioning. A blocker's central channel is tiny, maybe 2 millimeters. It can take forever for the lung to collapse, which frustrates the surgeon.
And the dislodgement issue?
They're just not as secure as a DLT. A little bit of coughing, or even just the surgeon manipulating the bronchus, can easily push the blocker's balloon back into the trachea, and suddenly you lose isolation and you're ventilating both lungs again, right in the middle of a critical part of the surgery.
That brings us to point 9, confirmation. This is absolutely critical. You've placed your device, whether it's a DLT or a blocker. How do you know for sure that it's in the right spot?
There are clinical methods, and then there's the gold standard. Clinically, we use auscultation. You follow a sequence, inflate the tracheal cuff, confirm bilateral air entry, then inflate the bronchial cuff, clamp the tracheal lumen, and listen. You should hear breath sounds only on the ventilated side and silence on the clamped side.
But how reliable is that?
Honestly, for the exam and for real life, clinical signs are unreliable. Sound can be transmitted across the mediastinum. The gold standard, the only acceptable answer for ensuring safety, is fiber optic bronchoscopy, FOB.
Describe the view for a correctly placed left DLT. The examiner hands you the scope. What are you looking for?
It's a two-step check. First, I pass the scope down the tracheal lumen. I should be able to clearly see the carina. To the right, I see the entrance. To the right, main bronchus is wide open and unobstructed. To the left, I should see the top of the blue bronchial cuff of the DLT, sitting just inside the left main bronchus, just below the carina.
What are you checking for specifically with that cuff?
I'm making sure it's not herniating out into the trachea, which would risk slipping, and that it's not so deep that it might be blocking the left upper lobe. You want to see just a sliver of blue.
Okay, that's step 1. What's step 2?
Step 2 is I pull the scope out and pass it down the bronchial lumen. Looking through the tube, I should see a clear, unobstructed view down the left bronchus. I should be able to identify the orifices of the left upper and lower lobes. This confirms my tube isn't too deep.
And when do you perform this check?
You check immediately after intubation while the patient is still supine. And this is the Viva trap that catches everyone. You must check it again after you have turned the patient into the lateral decubitus position.
Because the tube moves during positioning.
Almost always. Turning a patient from supine to lateral can move the carina relative to the tube tip by a centimeter or more. What was a perfect position, supine can become a disaster in the lateral position. You must reconfirm with the scope before the surgeon makes an incision.
Moving on to Part E, anesthetic management. Point 10, preoperative assessment. What am I looking for?
We use the three-legged stool approach described in Miller. It's a framework for assessing risk. The first leg is respiratory mechanics.
So, PFTs, pulmonary function tests.
Exactly. You're looking at the FEV1 and the FDC. The key number to remember is an FEV1 of less than 2 liters or less than 40% of predicted. If the patient is below that, they are at high risk for postoperative complications. We also calculate a predicted postoperative FEV1 or PPO FEV1 to see what they'll be left with.
Okay, that's leg 1. What's the second leg?
The second leg is gas exchange. You're assessing the lung parenchyma itself. The main test here is the DLCO, the diffusing capacity for carbon monoxide. A DLCO less than 40% predicted is another major red flag. And you'll look at the baseline arterial blood gas. Are they retaining CO2 at rest? Is their PO2 low on room air?
And the third leg of the stool.
The third leg is cardiopulmonary reserve. This assesses the patient's overall fitness. It's one thing to have good lungs, but can the heart and muscles handle the stress of surgery? This is where we look at things like stair climbing. Can they climb 2 flights of stairs without stopping? Or more formally, a cardiopulmonary exercise test to measure their VO2 max.
What's the critical value for VO2 max?
A VO2 max of less than 10 to 15 milliliters per kilogram per minute is associated with a very high risk of morbidity and mortality.
Let's talk about predictors of desaturation. If I'm looking at a patient's chart pre-op, what tells me this particular patient is going to be difficult and will likely turn blue during OLV?
There are 3 classic predictors. First, right-sided surgery.
Why right-sided?
Because the right lung is bigger. The right lung has 3 lobes and accounts for about 55% of total lung function. The left has 2 lobes and accounts for 45%. If you collapse the bigger lung, you are creating a bigger initial shunt.
Makes sense. What's the second predictor?
Low preoperative PO. If the patient is already struggling to oxygenate on 2 lungs while breathing room air, they have very little physiological reserve. When you take 1 lung away, they are very likely to become significantly hypoxemic.
And the third one is a bit of a paradox, isn't it? The VQ scan.
Yes. This is a great one to mention in an exam. A normal VQ scan is a risk factor for desaturation.
That sounds completely counterintuitive.
It does, but think about it. A VQ scan tells you how much perfusion is going to the lung that you are about to operate on. If that lung has normal perfusion, it means you are about to create a huge shunt when you collapse it.
As opposed to a patient with a big tumor.
Exactly. If a patient has a massive tumor that has already destroyed the blood supply to that lung, its perfusion on the VQ scan will be very low. In that case, collapsing it doesn't really change the physiology much. The shunt is already present. So paradoxically, a healthy, well-perfused lung is more dangerous to collapse.
Point 11. Induction and airway management. Any special considerations here?
The induction itself is usually a standard IV induction. The key is you need profound muscle relaxation. You cannot have the patient coughing or straining while you are trying to position a bulky DLT. That's a recipe for airway trauma.
Okay, what about tube sizing?
It's important. Too small a tube gives you high resistance and makes suctioning difficult. Too large a tube risks trauma to the larynx or bronchus. As a rough guide, for adult females, we use a 35 or 37 French tube, and for males, a 39 or 41 French.
You mentioned a key tip earlier, nitrogen washout. Can you expand on that?
Yes. Before you initiate OLV, you should ventilate the patient with 100% oxygen for a few minutes. The goal is to wash out all the nitrogen from the lung that you're about to collapse and replace it with oxygen.
Why does that help?
Because nitrogen is an inert gas. It has very low blood solubility. If you leave a lung full of nitrogen and air, the nitrogen acts like a splint, holding the alveoli open, and the lung collapses very slowly.
Whereas oxygen gets absorbed.
Oxygen is rapidly absorbed by the blood flowing through the pulmonary capillaries. So if the lung is full of pure oxygen, this process of absorption atelectasis helps the lung collapse much, much faster. The surgeon will thank you.
Point 12. Intraoperative ventilation strategy.
Right.
You said this is very high yield, and that practice has changed significantly.
It has. If you read an old textbook, it might say use high tidal volumes, 10 to 12 milliliters per kilogram, to prevent atelectasis and keep the SATs up. Do not say this in the exam.
Why not?
Because we now know that causes volley-trauma and barotrauma. You're forcing all that volume into just one lung. You're overdistending the healthy alveoli, causing inflammation, and setting the patient up for postoperative acute lung injury, or ALI.
So what is the modern standard? What should I say in the Viva?
You should say you will use a protective lung ventilation strategy. This has several key components.
Okay, what's the first one?
First, tidal volume. We use low tidal volumes, around 5 to 6 milliliters per kilogram of predicted body weight, not actual body weight. We are gentle with that one working lung.
Second component.
PEEP, positive end expiratory pressure. We advocate for the routine application of about 5 centimeters of water of PEEP to the dependent ventilated lung.
And why is that so important?
Remember our discussion about positioning. That dependent lung is being crushed by the mediastinum and the abdomen. It is desperate to collapse. Applying a little bit of PEEP acts as a pneumatic splint to keep those alveoli open and participating in gas exchange.
So low volume, add PEEP. What about the respiratory rate?
You adjust the respiratory rate to maintain a reasonable PaSO2. It will likely need to be higher than normal, maybe 16 to 18 breaths per minute, to compensate for the low tidal volume.
And what if the CO2 still climbs?
This is where the concept of permissive hypercapnia comes in. We're often willing to tolerate a slightly higher PaSO2, say up to 50 or 60 millimeters of mercury, as long as the pH is above 7.25. The priority is protecting the lung from high pressures, even if it means accepting a little bit of respiratory acidosis.
Okay, we are now in the thick of it. Part F, management of hypoxia. This is the big 20-mark question. The surgeon is working, you're on OLV, and the pulse oximeter starts that dreaded downward alarm. Tone-de-tone-de-tone. 88%, 85.
First rule is don't panic. Panic paralyzes your thinking and kills the patient. You need to have a calm, pre-rehearsed drill. But first, let's talk about point 13, causes. Why is this happening?
What's the most common reason?
By far, the most common cause is tube malposition. The DLT has slipped, the bronchial cuff has herniated back into the trachea, or the tube has advanced too far and is now obstructing an upper lobe. Before you think of anything else, you think about the tube.
What are some other causes?
It could be a simple obstruction, like a thick sputum plug in the airway. It could be bronchospasm, or it could be purely physiological. You have a massive shunt because the patient's HPV is poor, maybe because your volatile agent is too high, or your patient has low cardiac output leading to low mixed venous oxygen saturation, which makes any shunt much more impactful.
So point 14, the stepwise management of hypoxia. Walk me through the algorithm, the drill.
Okay, sats are falling.
Immediately turn your FiO2 to 100%. If you're using an aeroxygen mix, this eliminates that as a variable.
Okay, 100% oxygen. What's step 2?
Step 2, check tube position. Announce to the surgeon that you have a problem. Quickly auscultate, but most importantly, you must confirm the tube's position with your fiber optic bronchoscope. This is not optional.
So I have to pause everything and get the scope out.
You do. Pass it down the tracheal lumen first. Is the branchial cuff still in the bronchus, or has it herniated out? If it has, fix it. That will solve 90% of your problems right there.
What's step 3 if the tube position is perfect?
Step 3, suction both lumens. A thick mucus plug can completely obstruct a lumen and cause a massive shunt. Clear the airway.
Step 4.
Step 4, check and optimize hemodynamics. Is the patient hypotensive? Is the cardiac output low? If it is, the blood returning to the lungs is already very desaturated, which magnifies the effect of the shunt. Treat the hypotension with fluids or vasopressors.
Okay, so I've done all the basic checks. Tube is fine, airway is clear, blood pressure is good, but I'm still saturating at 85%. What's next? Now we have to start manipulating the physiology.
Correct. Step 5, perform a recruitment maneuver on the dependent lung. That bottom lung is squashed and likely has significant atelectasis. Give a sustained breath, for example. Hold a pressure of 30 to 40 centimeters of water for 20 to 30 seconds to pop open those collapsed alveoli.
And after recruiting?
Step 6, apply or increase PEEP to the dependent lung. If you started with 5, try increasing it to 8 or 10. This will help keep those newly recruited alveoli open. But be careful.
Why be careful? PEEP is usually good for oxygenation.
It's a delicate balance. If you apply too much PEEP to the dependent lung, you can overdistend it. This increases the pulmonary vascular resistance in that good lung.
And that diverts blood.
It diverts blood flow away from the good ventilated lung and forces it back into the collapsed non-ventilated lung, which actually increases your shunt fraction and makes hypoxia worse. You have to find the sweet spot.
Okay, so I've tried recruitment and optimal PEEP, and it didn't work. We are getting desperate. Sats are critically low. What's the big gun?
Step 7, apply CPAP to the non-dependent collapsed lung. This is probably the single most effective physiological maneuver you can perform.
Explain that. I'm applying pressure to the lung the surgeon is operating on.
Yes. You connect a special circuit and apply a small amount of continuous positive airway pressure. Just 2 to 5, maybe up to 10 centimeters of water, and some oxygen flow to the lung that is supposed to be collapsed.
But won't that inflate the lung and completely obscure the surgical field?
At 2 to 5 centimeters, it usually just puffs it up a tiny bit. It often doesn't interfere with the surgeon too much. But what it does, physiologically, is provide oxygen to those alveoli in the collapsed lung. So the blood that is inevitably shunting through that lung now has a chance to pick up some oxygen.
So it converts a pure shunt into an area of low VQ.
Precisely. It can raise the saturation from 80% to 95% almost instantly. It's a hugely powerful technique.
And if even that fails?
If that fails, you have 2 options left. Step 8 is to tell the surgeon, stop, I need to re-expand the lung. You abandon OLV temporarily, go back to 2-lung ventilation, bring the SATs up to 100%, and then try again once the patient is stable.
And the final, ultimate step.
Step 9, which is really a surgical maneuver, clamp the pulmonary artery. If the surgeon is doing a pneumonectomy or lobectomy, they can temporarily or permanently clamp the pulmonary artery branch going to the collapsed lung. This mechanically eliminates the shunt entirely. That is the ultimate fix.
That is a life-saving algorithm. So to recap the order, FiO2, check tube, suction, hemodynamics, recruit-dependent lung, PEEP to dependent lung, CPAP to non-dependent lung, then intermittent two-lung ventilation.
Correct. Memorize that order. It's logical, it's safe, and it shows the examiner you understand the underlying physiology.
Let's wrap up with Part G, postoperative and ICU considerations. Now that the surgery is over, what are we most worried about?
Point 15, postoperative complications. The biggest fear after major lung resection is acute lung injury, or ALI, in the remaining lung.
This is from the ventilation strategy we used.
It can be. It presents like ARDS. You see pulmonary edema, hypoxia. It can be caused by the volutrauma from over-distending the dependent lung or from reperfusion injury when the collapsed lung is reinflated. This is exactly why we are now so obsessed with the protective lung ventilation strategy.
What about other complications?
Nerve injuries are common. Brachial plexus injury from poor arm positioning during the long surgery and lateral, or phrenic nerve damage from the surgery itself, leading to a paralyzed hemodiaphragm, which can be devastating after a pneumonectomy.
And point 16, post-operative management. What is the most critical element here?
Without a doubt, pain control. A thoracotomy is one of the most painful incisions in all of surgery. If the patient is in agony, they won't take deep breaths, they won't cough effectively, and they will develop atelectasis and pneumonia.
So what's the gold standard for analgesia?
The thoracic epidural is the gold standard. A catheter placed in the epidural space providing a continuous infusion of local anesthetic and opioid provides excellent dynamic analgesia without sedation.
And if an epidural is contraindicated or fails...
A paravertebral block is a fantastic alternative. It involves injecting local anesthetic next to the spine where the intercostal nerves exit, effectively blocking the entire half of the chest wall.
Finally, Part H, exam integration. Let's create some quick reference comparison tables and highlight the traps.
A good idea.
Table 1, DLT versus bronchial blocker. Key pros and cons.
Okay, DLT pros. Fast and definitive isolation, lung deflation is quick, and you have large lumens for easy suctioning. DLT cons. More difficult to place, higher risk of airway trauma, and you must exchange it at the end of the case if post-op ventilation is needed.
And the blocker.
Blocker pros. Excellent for a known difficult airway, can be used in patients with a tracheostomy, and no need to change the tube for post-op ventilation. Blocker cons. Lung deflation is very slow, the narrow channel makes suctioning poor, and it dislodges very easily.
Table 2. Awake lateral versus anesthetized lateral position.
Simple. Awake lateral. Ventilation matches perfusion. Both are preferentially directed to the dependent lung. VQ matching is good. Anesthetized lateral. A massive VQ mismatch. Ventilation preferentially goes to the non-dependent upper lung, while perfusion preferentially goes to the dependent lower lung.
And the Viva traps. We've mentioned a few. The need to recheck the tube after positioning. The danger of high volatile agent concentrations inhibiting HPV. What about nitrogen?
Right. An examiner might ask, why did you use 100% oxygen for induction instead of an air-oxygen mix? The answer is not just about pre-oxygenation. You say, I use 100% oxygen to facilitate a nitrogen washout, as nitrogen has low blood solubility and acts as a splint, delaying the collapse of the non-dependent lung. Pure oxygen promotes rapid absorption atelectasis.
That's a very slick answer, and if they ask you to draw a diagram in the exam...
Be prepared. Practice drawing a simple diagram of the carina with a left DLT in position. Practice drawing the shunt diagram, showing mixed venous blood in a capillary bypassing an unventilated alveolus. And practice drawing the hypoxia management algorithm as a flowchart. Visuals break up text and score points.
So let's structure a long answer. Introduction.
Introduction, then indications classified as absolute and relative. Then physiology, with a big section on HPV. Then techniques, comparing DLTs and blockers. Then a detailed section on the stepwise management of hypoxia. Finish with post-op complications and management.
Let's summarize. Point 20. What are the key high-yield take-home points for the student heading into that exam hall?
Okay, here's the rapid-fire recap.
OLV is the deliberate separation of the lungs for surgical exposure or protection from contamination.
It creates a massive physiological shunt.
Your body's primary defense against this shunt is hypoxic pulmonary vasoconstriction. Do not inhibit HPV with high concentrations of volatile agents.
4. The left DLT is the standard choice for lung isolation due to the anatomical margin of safety of the left main bronchus.
The gold standard for confirming placement is fiber optic bronchoscopy, and you must recheck position after turning the patient lateral.
Ventilate the single lung using a protective strategy. Low tidal volume of 5 to 6 millimeters per kilodrama and add 5 of PEEP.
7. If hypoxia occurs, follow the algorithm. First, check and fix the tube. Last, apply CPAP to the non-dependent lung or ask the surgeon to pause.
Excellent postoperative pain control, preferably with a thoracic epidural, is critical to prevent pulmonary complications.
Fantastic. To the student listening, you have the knowledge now. The key is structure. Structure your answers clearly. Use headings, bullet points, and diagrams. Don't ramble. Be the safe, calm, knowledgeable consultant they want to hire.
Exactly. Go draw that hypoxia algorithm right now. Burn it into your memory. Good luck.
That's it for this deep dive. We'll see you next time.